Hello, and welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with the Digital Pathology Association and Path Presenter. Our case today, not particularly a diagnostic problem, but it's an interesting topic. A 40-year-old patient who has a history of prior granular cell tumors involving the bowel. And so he comes for evaluation and reassessment to see if other lesions remain. There is a bit of a familial history as well, but endoscopically these lesions are identified in the cecum. At low magnification, we can see that there are several spots that merit attention. Here's a little area, here's an area, probably the other side of that here. And this is located primarily in the submucosa. There's a bit of infiltration of the surrounding fat. And here it butts up right against the mucosa. So in this area, we can see that there's a little bit of spindle cell morphology, fairly eosinophilic cytoplasm. So looking at this lesion, we might think about common things like smooth muscle tumors. We might think about mucosal Schwann cell hamartoma. But of course, we have this unique history of patient having had prior granular cell tumors. So that also should be heavily on our list, though this is an uncommon location. And here, as we look at higher magnification here, I think we can see that there is a very granular appearing cytoplasm. The nuclei are very bland. So other neural lesions might be in our differential here, but given the history, we would certainly lean towards granular cell tumor with a little bit of spindle cell morphology. Well, as we may have spoken before about the value of knowing where we are in evaluating these spindle cell lesions of the GI tract. I know Dr. Montgomery several years ago gave a wonderful talk on this very topic, and it impressed me greatly, and I've used it a great deal in my evaluation. But as we think about mucosal lesions, Schwann cell hamartoma is one of the more frequently encountered ones. Less frequently, Kaposi sarcoma, neural lesions like perineurioma or neurofibroma, and uncommon lesions like the tactile corpuscle-like body. Leiomyomas sometimes can involve the mucosa, though usually it's the interface between the mucosa and the submucosa that is involved. Submucosal lesions most commonly are granular cell tumor and ganglioneuroma, though again these are uncommon. And then lesions that may extend downward like Kaposi's or upward like GI stromal tumor or schwannoma. When we get out to the adventitial layer, inflammatory myofibroblastic tumor, fibromatoses, sclerosing mesenteritis more frequently encountered, and usually do not extend into the wall in my experience, though certainly some transgression into the muscularis might be seen. So one of the clues in evaluating GI biopsies is, of course, to examine all the fragments. So here's a patient with symptoms of GERD or reflux disease. And in fact, we can see that there's an abundance of eosinophils, edema, a few scattered lymphocytes in this squamous mucosa. So clearly it's very actively inflamed, and a lot of eosinophils. And if it's not GERD, it's eosinophilic esophagitis, depending on where we're from. As we look around, however, and look at all of the fragments, scanning through here, we want to make sure that we don't miss anything, because lo and behold, hiding here in one of these fragments is this. And as you can see, based on our topic, you would make the diagnosis of granular cell tumor here associated with eosinophilic or reflux esophagitis, depending on the location. So the diagnosis of granular cell tumor is confirmed, and the lesion is resected. And here we see that it was just deep to the mucosa. Now, over here at the edge, we can see here the muscularis mucosa does begin to get splayed and pushed upward as this lesion begins to grow. So probably this lesion is originating in the submucosa, as you see these adjacent vessels, and extending up into the lamina propria of the esophagus. Well, granular cell tumor most commonly occurs outside of the GI tract, usually in the tongue, oral cavity, and the skin and subcutis. But when it does occur in the GI tract, the esophagus is the most frequently encountered lesion. The incidence is usually in adult life, and most often these are asymptomatic. As we've mentioned, these lesions are S100 positive, but they can also stain with myelin basic protein or PGP 9.5. And they would uniformly be negative for markers of GIST, smooth muscle tumors, neuroendocrine tumors, and so forth. Of note is that up to 30% of the patients, as our patient was, can have multiple lesions, and a fair percentage will also have a familial association. One of the familial syndromes with which this is associated is so-called leopard syndrome, which is caused by a mutation in the PTPN11 gene. And this acronym is derived from lentogenes, electrocardiographic abnormalities, ocular and hypertelorism and obstructive cardiomyopathy, pulmonary stenosis, genital abnormalities, and retardation of growth and sensorial neural deafness. So all the letters get included, and a few skipped over. Probably because this does not account for that full 8%, there are probably other genetic factors that play in these other familial associations. So just to round out our presentation, here is another lesion from the skin. As you can see, no particular grun zone here, but the nice characteristic morphology with packeting of these cells, sort of amphiphilic, very granular cytoplasm, and uniform round nuclei, very small nucleoli here and there, no mitotic activity, and not much pleomorphism. Other locations you might encounter this is a breast biopsy. And here, I don't think you'd confuse this with infiltrating ductal carcinoma, but you might be concerned for a while if you looked at this and thought, gee, that looks like an infiltrative pattern. What's going on? What is this? So you got to remember that's one of the skin adnexal structures where skin tumors can occur. Elsewhere in the soft tissue, it can arise in subcutaneous tissue like this lesion. Again, and I show you this lesion primarily to show that not all of the cells are uniformly granular. So this has a fair population of these slightly cleared out cells with paler eosinophilic cytoplasm. These are still part of the tumor. They're just less granular than these other cells. And here we see one that's very hypergranular. So the granularity in any given cell can be variable. Now, occasional malignant varieties can be encountered, and what are the hallmarks that should make you begin to think of that? Well, as you can see, this looks very similar to that other cutaneous one we saw, except that as we come into higher magnification, we've got a couple of really funky looking nuclei here. Here's one, here's some here, here's some here. So when you begin to see nuclear pleomorphism or necrosis, you might want to think twice. Mitotic activity, these are features to begin to make you look more carefully. In fact, back in the 90s, Dr. Fanberg-Smith and her colleagues identified several criteria that they felt would be predictive if 3 or more of them were present. Those included necrosis, spindle cell morphology, vesicular nuclei and nucleoli, mitotic activity greater than 2 per 2 millimeters squared, and nuclear pleomorphism. Of note, up to 40% mortality at 3 years if you had 3 or more. And 50% would have metastatic disease in a fairly short period of time. So not trivial potential consequences in the malignant cases. Here's one such case, and we see a little bit different packeting pattern here, a little bit less of the discrete packets. Maybe a little suggestion that there's some spindle morphology, but that's not the reason this was called malignant. It's called malignant because you've got pleomorphism, you've got mitotic activity, like here, even atypical mitoses. And as we look at these nuclei, I think you can appreciate that they're much more vesicular and here's a nice area with very prominent nucleoli in these nuclei. So these are the features to begin to highlight for malignancy. So our final sign-out diagnosis today is a granular cell tumor of the colon, familial case, with a patient with multiple granular cell tumors historically. Appreciate you joining me, and if you like that, please subscribe, share it with colleagues or friends, and I'd really be interested to know if you've encountered granular cell tumor in an unusual location, and if so, what your experience was. Until next time, thanks so much for joining me.